Okay, so good afternoon. I hope you have been enjoying the sessions. Again, today we are going to speak a little bit about the partial implant treatment. So, cases of when we have failure of more than one tooth, and where we go for small bridges. So I'm going to share a little bit of my clinical experience. What do we do in these cases? How we diagnose, how we plan, and what are our surgical protocols. So I think it is a very interesting session, and I hope that you enjoy it. Meanwhile, I want to thank you all for the message I have been receiving. Thank you for everything, and I'm glad I've been helping you to improve your clinical skills. Any question that you might have, again, please contact through my social media, through Instagram, Facebook, LinkedIn, whatever you feel like to. So because I'm actually here to be able to share my practice with you, my knowledge, my experience, and also so that you can learn more and more and can help your patients in a better way. So today, as I told you, we are going to talk a little bit about the diagnosis for partial cases, how the planning is for these partial cases, how the surgical protocols are for interior, for posterior areas, and especially starting to talk a little bit about the tilting of the implants. As you know, use it for the Olden 4, but we also use it for the partial rehabilitations, as I'm going to further in this lecture share with you. So when we think about the patients that start to lose teeth, as you know, again, losing teeth is a very early sign of aging. Nobody wants to get old, uh, and basically these patients start to feel themselves shy, and also start to have problems with dentition, starting to have problems with the function, with the speaking, with the masticatory problems, and basically they come for us for some help. So when we start to lose more than one tooth, and we have an area of teeth that it's missing, what kind of solutions do we have? Of course, we know we have the traditional removable solutions that have many, many, many years. And unfortunately, to substitute the three, four teeth, we end up having to have something that it's removable and will fit basically the whole mouth. The only advantage of a removable prosthesis is basically that in terms of costs, it is actually cheaper. In terms of doing it, it's also easy to do. It's very dependent, of course, also on the type of lab that you have. But it's a cheap solution, and unfortunately still very, very popular. Although people have a lot of difficulty in adapting to it, because it's something that is removable, it's constantly uh, moving inside the mouth, and also it will basically accumulate more bacterial plaque, which is not good for the patient. Besides this, it will have difficulty in having a good oral hygiene, and also what happens is that the patient are always afraid that they will fall out. Also, when they're speaking, they continue to be shy, and it's not a very comfortable solution, nor in terms of comfort and nor in terms of health, because it has tendency to damage the neighboring teeth. But nevertheless, it's a solution that it's cheaper, and sometimes we use it as a provisional solution, while the implants are healing if they don't have enough primary stability to be loaded immediately. Second solution is a bridge, a 3-unit bridge or a 4-unit bridge in this case, because we are talking about partial cases. So when when two teeth are missing, and when the neighboring teeth, they have the need of doing a fixed crown. So if you have neighboring, as you can see in the figure in the middle, if you have neighboring teeth that are in need for crown treatment, basically, of course, you can do a bridge. So this is of course a solution, but it's a solution where in terms of costs it's more or less than having also fixed teeth over implants if the two ones are missing. And if the teeth are okay, you are going to destroy, to damage the neighboring teeth just in order to have a fixed bridge. So basically, the best solution is to have implants and bridge over it. So advantage of it is of course that it's fixed, so it's a non-removable solution, it's a fixed solution, very easy to adapt, but of course it's more expensive, and we have the need to have the prosthetic space to accommodate the bridge, but also the bone available to have the implants placed. So when we talk about the planning for the implants, we know that when we place implants next to each other, according to the several studies of Tarnow, for example, in order to have papilla in between them, and in order to have a good healing and a good osseointegration of your implants, we should have between 3 millimeters of distance between the two adjacent implants. So you have to be aware of this, that between implants you want to have at least 3 millimeters in mesial distal, and between an implant in the tooth, like we talked already in the last lecture that was about single implants, between the implant and the tooth you have to have at least 1.5 millimeters of space in order to have a good bone healing, a good healing of the soft tissues, to have papilla between them. So all these rules are essentials in order to be predictable and to have good results in the future. So this is basically what we want. So when we look at our cases, we always have to put this in mind, to have this in mind. So imagine that we are planning to have all these implants because we have all these teeth that are missing. So imagine that we only have the central incisive, the canine, and the wisdom tooth there. So what kind of planning do we have to have in mind in order to check if we have the available bone to place these implants? Well, basically, if I want to place that implant in between the teeth, I have to understand that if it's lateral incisive, and if I want to have my implant apart from the neighboring tooth, I have to count at least 1.5 millimeters to each side, okay, which brings me to 3 millimeters. So if I have already 3 millimeters, I have to understand the narrowest implant that I have. In this case that I use is a narrow platform 3.3. So I have to have at least in order to be able to place that implant there, which is a narrow platform implant, okay, I have to have at least 6.3 millimeters between both teeth, okay? So this is very, very important that you start planning, that you start to realize how much is the crown in terms of mesial distal length, okay? This is very important. How much do I have in terms of bone between roots of the neighboring tooth, do I have the space to accommodate there an implant? So this is crucial and very, very important. Then we move and we start to think, okay, now I want to place a premolar, the first premolar. So the premolar is adjacent to the canine. So again, I have to have at least 1.5 millimeters there between my implant and the root of the canine. And imagine that I want to place a RP platform implant. So RP platform implant, in this case a 4.0, I have to see, okay, if I want to put this implant, where can I start to drill? So I have to count 2 millimeters, which is the middle of my implant, plus the 1.5, which is the distance that afterwards I will have to have between the implant and the neighboring tooth, okay? So I will start, I measure 3.5 millimeters, and this is where I start my drilling. So this is very important. Of course, you should you should do some guides if you want, surgical guides, where you can place the crowns, where you can have everything already planned, and then you use that guides to know exactly where you should start to drill and where you want to place your implant. But if you don't have the guides, you have to understand the basics, okay? And this is, if you go freehand, the basics are these ones. You have to have this knowledge to know exactly where you have to drill. Now imagine that you want to drill for the first premolar and the second premolar. So I want to drill for the second premolar. So I have to know exactly where I have to drill to start my drilling. Now imagine I also want to place a RP platform implant. So, and I have to have at least 3 millimeters between the two implants. So from where I start drilling for the first premolar to where I'm going to drill for the second premolar, I have to have at least 7 millimeters apart from each other, okay? So this is crucial, this is very important, this is the minimum if you want to have good results. Now imagine that I'm going to place a molar, first molar with a WP pet form, which is a 5.0. So again, here between the second premolar and the first molar, I have to go with my drilling after 7.5 millimeters from this drill of the second premolar to the drill of the first molar. So now imagine that it's very, very, very common that for a bridge of 3 unit bridge that I only use and I only do 2 implants. So if this is the case, I just have to sum up the 7 plus 7.5, and from where I started drilling for my first premolar to where I drilled for the first molar, we have to measure at least the 14.5 millimeters. Okay, so these are basically the basics of the drilling for the bridges, because we want to have the implants exactly where the crown is coming out, and this is very, very, very important. Of course, my advice to you is that if you are able to do a scanning, if you are able to work with digital and do a guide, even if it's just a guide for the first drill, you can go and use it, okay? You can also do a wax up in a model and do a guide, which is done by the model, just a transparent guide where you know exactly where the crowns of your tooth are going to be to guide you with the drillings. But if you go freehand, this is always the basics that you have to know. Okay? This is the same. So between two molars, you have to have these 8 millimeters when you start to drill for the first drills. Because again, between the implants, you have to have at least 3 millimeters apart from each other. Okay? So this is very important to have this in mind, this planning, and how you go to see if you have space available to accommodate all these implants. So now we know, and I show you through this clinical case. This is a clinical case that a patient came to me many years ago. This is basically, we have the OPG, and this is how I show to the patient how the planning is. So we can see that we had here lack of teeth in the sixth sextant of the patient, and it was a very thin ridge. So in this case, we planned for 4 implants, okay? And in the upper jaw, as you can see, I already talked to you a little bit about the tilting implants, but as you can see, this bridge on the third sextant is not viable, so we have to extract that root of the tooth number 27, and here we have to check if we have available bone to accommodate what we call a half all-on-4, so a straight implant and a tilted one. So in this case, as you can see, these are the picture, the intraoral picture. You can see a very thin ridge, a ridge that it's demanding in terms of rehabilitation, in terms of placing the implants. And this is where it is crucial also to have implants that are also thinner, like the NP platform. So you can see here, I placed implants in the premolars and the molars, all of them, and we can see exactly the distance between all of the implants. So this is very important that you have always in mind the distances, so that you can have in the future a perfect good healing of your soft tissues, but also of the hard tissues. Okay, so you can see here we placed the multi-units. In this case, we place multi-units of 2 millimeters in the implants. Okay, and the second molar, I placed the healing abutment because I did not want to load it immediately. So we loaded the other 3 with the bridge that it's connected, that it's all together. And here is the impression. So we do an impression to multi-unit to abutment level, and with the abutment level, as you can see, we do a bridge, and after uniting, as you can see, the impression copings with Duralay, we use only putty silicone because we just want to know exactly where we have our implants coming out. Okay, so we do not want to care about how the soft tissues are, because actually after 1 hour, 2 hours, they have already healed. So it's important to have the notion and to have a good model of your implants, but the soft tissues will change immediately. And here we can see the bridge in place of the 3 teeth, 2 premolars and 1 molar. Here with the suture, and here you can see already the final crowns. Okay, so here you can see the final crowns, how important it is actually to place the implants where they are supposed to be. Check exactly very well the distance between the teeth, the distance between the implants, and where you want your implants to be placed. And here you can see the OPG, the first with the only with the lower ones, and the upper already with the bridge in the third sextant, already with a provisional bridge. Good. So again, and in this case, you have to understand the abutments are very important. We have angulated abutments, we have multi-unit abutments. So every time that we go for more than 1 unit, it's good. If you are going to do a bridge, that you plan also to have these multi-unit abutments. The multi-unit abutments are very, very helpful. You have them for the external connection and also for the internal connection. And basically they will have, I would say, three main roles. They play three main roles, which for me are very important. They will help in the immediate function because they will be the weakest link. The weakest link is between the crown and the abutment, and on between the and not at the head of the implant level. So this is very important. If something unscrews, if the bridge breaks, if something happens, it is important to understand that basically these multi-unit abutments will actually protect my implant. Also, by the time that we place our abutment, everything will be done at the abutment level. Immediately we are protecting our soft tissue health, our peri-implant soft tissue health. And this is crucial because it is between the soft tissue and the abutment that we will have this biggest biological sealing. And for me, I think that the multi-units are one of the biggest secrets of the All-on-4. I already told this several times, but it's important because we will have this sealing, and this biological sealing of the soft tissue, what we call the muco integration, will actually seal will act like a barrier for bacterium plaque not to go, for the bacteria not to go inside the bone. And of course, in terms of the prosthesis, we know that these multi-units can also compensate any time of discrepancy that we have. Sometimes some of the implants might be deeper than the others, so we will have these multi-units compensating, having the bridge at the same height, which is very, very important. Also help sometimes if we have to tilt a little bit the implant to the buccal side because of the bone that we have. These multi-units will compensate in terms of giving us the palatine access of the bridge, and also, of course, the passivity of the prosthesis. So this will help a lot in the passivity of the prosthesis. Now, coming to the anterior area and how do we plan? What do we do when we lack 4 incisive? So it is a case that that I think it's very common. Now, it's not very common, but it's common to have the second sextant or the fifth sextant missing, especially when we have aggressive periodontitis, people that had aggressive periodontitis and had a pattern of the incisive molar. So we see these people that have lost a lot of bone in the area of the molars and the incisives. So this is something special, and I want to share with you how do we plan. So when we miss the 4 incisives and we want to place the 4 teeth, how do we plan this? How many implants do we plan? Where do we place them? This is very important. So the challenges that we have here are basically that the challenge of bone volume and height, the volume of the gingiva, the aesthetics, and also the occlusal loads, especially in terms of the guides, anterior guides, lateral guides. So these are the challenges that we have. Now, how many implants should we place? How many implants are adequate for this? And of course, each case is one case, but how many implants do you usually place? Well, basically, in terms of number, we can place 4 implants, although it's very challenging to place the 4 implants and to have the bone and the mesial distal place to accommodate all the 4 implants, and to have all these rules that I told you in between the implant and the canines to have 1.5 millimeters, and in between the implants to have 3 millimeters apart from each other. So it's difficult to have and to achieve good results. Now three is also an option. And where should you place the three? Should you place the three in the incisives, central incisives, and in one lateral, or on the other? Well, and two is also an option. And if you place two, where you place them? Do you place them in the centrals or do you place them in the laterals? Well, basically, and also you can place them, of course, one in the central incisive and one in the lateral incisive. So all of this has advantage and disadvantage, basically in terms of the occlusal loads, how you manage to do this, also in terms of the bone volume that you have. So in terms of where it is more advisable to place the two implants, well, basically I want to tell you that I always go only for two implants when the four teeth are missing. Where do I place them? Well, that is going to be guided to me on how I have the most bone available. Okay, so in this case, we check the CT scan. We do in the models we check the teeth, how much space we have. We design the teeth. We make a diagnosis, and we can make also a surgical guide. And here, this is a very easy surgical guide to do. And we can then place our implants and our bridge, okay? So the advantage is that many times if we go just for the laterals, because the laterals usually are thinner, in order to have a good outcome of the good emergency profile, sometimes you had to use NP implants. In the area of the centrals, you can use easily RP implants because the emergency profile of the central incisive is larger. So you can see this is the case. Dr. Carlos Marquedes. Another case. This is a case of a very young patient that she was using removable denture. Again, she had no, she was lacking the four incisives. As you can see here, she's lacking the four incisive, wearing removable denture for a long time. And we planned here to go for two implants and a bridge. So you can see here, this is the evaluation of our CT scan. We have a lot of bone. We have 20 millimeters of bone height, okay, with more than 5 millimeters of width, although the bone looks very soft. So this is the surgery. We went for the surgery. So we give the anesthesia, and then we check where we want to open our flap. Here, what we do is we make two release incisions. So we make incisions and leave the papilla between the canine and the lateral. And then in terms of buccal palatal of our incision, we check if we have a need to compensate any kind of concavity that we might have on the soft tissues. So here we can see we open a good flap in order to see all the bone available that we have. And this is a guide that it's very easy to do in the lab, because you basically you make the trying of the crowns that we want, and you just do this surgical transparent bar guide that it's very easy. So then I will start with the osseo director. So this is the first drill where I'm going to choose what the length of the implants that I want. Okay, I place my pin. I drill both of them together. So we can see here we will be more than 3 millimeters apart from each other. We are okay. We use the guide in order to check if we are exactly where we want. Okay, And now I'm going to use the Osseo Shaper. This is a very nice drill for the N1 implant. So it's without water and low rotation. Okay, and here I place a 4.0 implant of 13 millimeter. So I'm placing the implant, starting with 30 Newton, going to 50, and now I am happy. I am going to check on the stability, and I try to place a little bit deeper. So I check and I go now for the other implant. So again, I use the Osseo Shaper 1. Now I take it out. Good, and now I will place my implant again. So I start placing my implant, 30 Newton, it stopped with 30, I go with 50, a little bit more down. And I check now also if I have to go a little bit deeper with my manual torque wrench. Okay, and you see this line, so it has to be facing this line to the buckle side. As you can see here. Okay, so now I'm happy, exactly where I want them to come out. Now I'm going to connect also multi-unit abutments, 1.5 millimeter to both of them. So both of the implants are placed under the bone. And now I'm going to suture everything. So I give the suture, here is a 5-0. And after this, we have our bridge already selected. Here we are starting to reduce our cylinders. So we check in terms of occlusal high if we have the space available. And now we are going to open. We are going to open here in order to realign the bridge. So we protect here the soft tissue with the rubber dam. Now I use the guide in place also to help me to stabilize and to realign. Good. I can place some cotton pellets, whatever, to help me to realign. And now I just place some acrylic and wait for the setting. So I'm going to wait for the setting, and now I'm going to unscrew the prosthesis. And now I'm going to finish everything. So I can use here also the abutment replicas to finish my, as you can see, to finish my bridge with powder and liquid. Here, salt and pepper. Philippe adds a little bit more of salt and pepper. So acrylic, and now just leaves everything to set and finish everything. So as you can see, if you plan this, and this is planned in analogic way, it's very easy to do it chair side, and very easy to have it everything prepared and planned also for your for a case where you have um, this missing of the 4 anterior incisives. So we'll screw with 50 Newton. It's very good. We check the occlusion, so we don't want to have contacts in the occlusal. And we don't want also to have interference in the anterior guidance and lateral guidance. Okay, so again, when we have the missing of our anterior 4 incisives, as you can see here, we choose where we have the best bone available to accommodate the 2 of the implants. So in this case, we have chosen to accommodate them in the area of the centrals because we had a lot of bone, and also because in the areas of the centrals it allows us to use an implant of at least a regular platform. So be aware of the emergency profile of your teeth that you have, and this will help you to choose also where you want to place your implants. Now let's go to another clinical case. This is a clinical case where you can see again exactly where the problem is. Now the problem is in the 4 incisive, not the upper ones, but the lower ones. So we had here a patient that had a periodontitis, and which the lower incisive have over erupted. So they had mobility, they are already fertilized to each other in order to try to maintain them, but here they had a very bad prognosis. So here the treatment plan was actually to extract them, and in the same day, as you can see, to place implants. Now when we go for the implant placement, we have to again choose where we are going to place the implants. So usually in the lower incisive, I usually place the implants between, usually in the lateral areas, or that they have a gap of a tooth between them, because they are very thin, so we don't have a lot of space. And in this case, the best bone available was actually in the area of the 32 and the 41. So this is where I plan to place my implants. And this is where I placed my implant. And here you can see with the immediate bridge done. Here you can see the implants placed. In this case, 2 NP platform implants with the multi-unit abutments, the provisional bridge, and here you can see the patient already with the final bridge in anterior view, lateral view. And also here the final OPG, already also with the first molars in place. So it's very, very important to plan well your case, and it's very important to understand exactly where you want your implants to be placed. So again, mesial-distal space first. Second, amount of bone that you have, where do you have the best bone available, okay? And emergency profile of your teeth. So you have to take these 3 in consideration in order to understand where you're going to plan your 2 implants when you're going to substitute the 4 incisives. Now let's go for the posterior area. Posterior area is also challenging. Not so challenging in terms of aesthetics, of course, as the anterior is, but we have other challenges. What challenges do you have? We have the challenges of the bone that we sometimes lack, we have the challenges also of the occlusal loads. Okay, so this is very important. So when we start to to plan for our cases, if we have more than 8 millimeters in that area, being in the first molar and in the area, for example, of the premolar, of course we can go for standard implants. When the bone height starts to be between 4 and 7, we start to go for short or tilted implants. And sometimes we go to tuberosity implants and zygomatic implants. So let's see how we plan. So here, imagine that we have this case that we have at least 8 millimeters in the area of the first molar. So in this case, you can see we can go with standard implants. We place our implants and then we place a bridge with no complications, nothing special, all good. What type of challenges do we have? We know that usually when we start to lack the teeth, we start to lack the bone. We start to have sinus pneumatization, and this can cause basically a huge challenge. What can we do? Do we go for augmentation procedures? Do we go for sinus lift? Or we can have the other types of solutions, like I told you, by tilting the implants. So not only the challenges are in terms of bone volume and height, but also the bone density. Usually in the posterior areas of the maxilla, we have tendency to have bone with less density. We have D3, D4, and besides this, we have bigger occlusal loads in that areas because it's very, very near the TMJ junction, and basically you'll have a big masticatory function and big loads in that areas. So when we lack the bone in the posterior area, we have several options. We have augmentation procedures. So, well, these augmentation procedures where you have to take bone out from other area and place it in the posterior areas. It's very discomfort for the patient. It has higher costs. Patients will stay at least 4 to 6 months without fixed teeth, and it's more demanding in terms of surgery and in terms of risks. And according to Chiapasco, we have a success rate dependent on also very much on the surgeon skills, and it goes between 60% to 100%. We also have sinus lift procedure where the patient discomfort is higher than because it will involve 2 surgeries. The costs are also higher, and the patient will remain without fixed teeth for at least 4 to 6 months. Surgery difficulties are also higher, and surgery risks in terms of a normal sinus lift are, of course, also are low. The success rates are also very variable. According to Wallace, it depends. It has very many factors which are dependent on this, and it ranges between 61.7% and 100%. Now, we like to go away from these augmentation procedures and from these sinus lift for partial cases. If we are able to have other solution, that's what we aim for. So short implants, we do it many times when we have this type of sinus anatomy. So we go for short implants. Short implants are considered implants between 7 and 8.5 millimeters. The discomfort of the patient is low. The costs are the costs of the implants, so no extra procedure. And we can load the implants immediately if they have good stability. It's easy to do. It's just a short implant, and we don't have the surgery risks are low. We have very high success rates of short implants that are described. Basically, they are more or less the same as standard implants, 92.2% between and 100%, like it was stated by Srinivasan in 2012. Sometimes we don't even have the place for the space enough for these short implants, and this is where we start to tilt our implants. So we start to tilt our implants when basically we have about 1-2 millimeters in the area, 2 millimeters, 3 millimeters in the area of the first molar. But by tilting our implant, we are able to have better bone in terms of volume and also in terms of density. And so by tilting our implant, we are able also to go for bridge without needing to do any augmentation procedure, as you can see in this orthopathomography. So the tilting of the implant support will be moved to the posterior, so we will avoid to have bigger cantilevers. The implant length can be increased by that, and the implant will follow dense bone structures, enhancing like that a good primary stability. So we can see that tilted implants have high success rates between 95.3% and 100%. Okay, and we can, if we have good stability, we can immediately load the implants, and it has low risks. And of course, it's a surgery that it's already more demanding than when placing straight implants, but it has a quick learning curve. If you want to learn, I would be more than happy to show to you. I'm going to show through a clinical case how to do it. So we can see several authors have been publishing about tilting implants since Krekmanov in 2000. Then we had Aparicio, Malo, and you can see that also for partial rehabilitations we have very high success rates, not only immediately, but also long term. So we go through a clinical case in order for me to show you exactly what do I mean. So this patient, tooth number 14, was hopeless, and also she wanted to have fixed teeth where she lacked the teeth. And so basically what we did is that we planned for her to do um, two half All-on-4 in the upper jaw. So how do we do this? Here you can see the pictures from the right side of the patient from the first quadrant. So we have to know exactly, after having done the extraction of the first premolar, what do we have to check? We have to check exactly the amount of bone that we have. So make a small hole into the sinus, and with my periprobe I see exactly where I have my sinus window. So I probe it, I can even mark it if I want, and then I start drilling, and I will drill both of my implants at the same time, which means I will drill the anterior one, as you can see with my pin guide there. I will drill my anterior one, and I will drill with the 2 millimeters drill also the tilted one, in order to beneficiate from all the available space that I have. The same on the left side. So when I'm drilling, I'm doing both of them at the same height. Then I will place again my implant, and I drill according to the type of bone that I have, more or less, again, in order to achieve a good primary stability. So I drill and I place my implants. So after having placed my implants, I connect the abutments in order to have a good outcome of the abutments in terms of prosthetic prosthesis. Afterwards, what I do the impression, and I send this to the lab. After this, I place my crowns. Here you can see my bridges are in place, upper and also the lower bridge, all with the immediate function. So you can see this is a straightforward case for us in terms of no doubt in placing angulated implants, tilted implants in the areas of the first molars. In the lower, as you can see, we did straight implants in the fourth quadrant for the tooth, for the bridge between the premolar and the molar. And this is our patient. Beautiful case from my colleague Ana Teresa with the rehabilitation in place. So here you can see these are the cases, and here the periapical x-rays and the orthopathomography with the implants in place. So after this, when we don't have any space in that area and just have a space available to place one straight implant in the area of the first premolar, for example, but we still have space in terms of bone for the tuberosity of the or the pterygoid, this is also an option. We can go for that type of rehabilitation. So in this case, for example, I'm going to show you how important it is. This is very important because this is also an option. And from what you can see in terms of success rate, it has very, very high success rates between 91.7 and 100% according to BIDRA. So of course, it's already a little bit more demanding in terms of the surgery compared to the tilted implants that you have in the maxilla, but it also has low surgery risks. So this is one of the case. The patient came and the bridge that he had on the third sextant was loose. So unfortunately, the tooth number, the second molar and third molar were lost. And here you can see these are the intraoral view. He had complaining about the food impactation, bleeding around 27, and also bleeding mobility of the bridge. When we look at the CT scan, we can see that we have space enough to place, in terms of bone, an implant in the area of the premolar. But then with what we have in terms of infection of the molars, we lack the bone available for that. So what we have in terms of solutions, we can go for the extraction of the two molars. First option, with 4 months sinus lift, then after 6 months implant in 25 and 27, and after 6 months 3-unit bridge. We could go also for all of this, and in the day that we did the implants, we could go for an immediate 3-unit bridge. So this is option number 2. Option number 3 is to do the extraction and the sinus lift in the same day, and afterwards 6 months of the implant and then a 3-unit bridge. Or we could go for extraction of these two, immediate implant in the area of the 25 and immediate tuberosity implant in the area of the 27, and an immediate 3-unit bridge. So from all of these solution, we discussed with the patient, and for us the most reliable one was actually the solution number 4, which means that in the same day we extracted that tooth, we cut the bridge that he had, we did the implant in the area of the second premolar and a tuberosity implant. So you can see here, so the first phase we cut the metal ceramic bridge, distal to tooth number 24, extracted the teeth 27 and 28, and then we did the implants on the 25 and tuberosity implant in starting in the root of the 27. So after this, we immediately placed also our multi-unit abutments, 2 millimeter in the implant 25 and a 30-degree 4 millimeter abutment in the area of the tooth number 27. And we loaded it with a 3-unit bridge from 25 to 27, as you can see in the picture on the right side. So after the healing, after more or less 4 to 6 months, we went for the final procedures. Here you can see this is still the provisional one, and here you can see the patient already with the final bridge in place, and here also with the OPG with the final bridge. So as you can see, this is also another option that I like to share, because many times we have the tendency, and from what you hear from the traditional lectures, are usually the straight implants, but tilting the implants also for partial cases. This is something that is very, very common for me. I've been using for 17 years now, and it has fantastic results and can avoid many complex surgeries and many other complications and risks. So zygomatic is also a solution for partial cases, although I don't use a lot. Okay, it's also a solution between when you lack the bone in that posterior area. Also, zygomatic implants have high success rates, as you know, but have higher surgery risks, and it's a higher demanding surgery. So from this table, you can understand what possibilities do you have in terms of surgery to rehabilitate the posterior area of the maxilla. Another thing that it's very important is that, as you know, we like to go for immediate function, and it's very important the occlusion. Now, in the papers that we have published, here is the paper from Malo and Miguel Nobre in 2011 in the partial rehabilitation of the posterior maxilla using one straight implant, one actual implant, and tilted implants, like the half alone 4, like I told you. So for this study we used 35 patients, where the success rate of the implants was 98.8% with 8 years follow-up. Mean bone loss 1 millimeters at 1 year follow-up, and 1.75 millimeters at 8 years follow-up, with no significant difference between the actual and the tilted implants. Also, another study that we published also for actual implants in immediate function for partial rehabilitation maxilla and in the mandible. What we have here is basically that we have with 199 patients with 481 implants placed, with 99% of implants with 5 years follow-up, the success rate, and 96.7% of success rate with 10 years follow-up. Mean bone loss 1.79 5 years and 1.89 at 10 years. Also very important to understand is the mechanical complications, which means unscrewing of the screw, unscrewing of an abutment, sometimes chipping of one of the crowns, or breaking of the provisional prosthesis. So we had 21.6% in 10 years of follow-up. Okay, also much more common in much more common in the all acrylic bridge, a provisional bridge. And also very important to understand biological complications, 3.3% of the cases. So it's a very low rate, but nevertheless, it's very important to have a good compliance with our patients. So when we rehabilitate our patients with the bridges, it's also important to understand that the bone stress may have both short and long-term influence on implant survival. So it's always very, very important to check periodically the bridges and how the load is and how the distribution of the occlusion is in your implants. So what does the literature says for immediate function? Says that it's possible to load an implant immediately, that different clinicians have different results, that immediate load is better than delayed immediate load, which means in the first 2 months, and that good primary stability is a precondition for success. Occlusal contacts should be avoided during osseointegration period. Well, sometimes it's possible. If I'm going for the single tooth, like we talked last lecture, yes, please try to protect it and avoid the occlusal contacts in the osseointegration period. Sometimes when you are going for a bridge, you try to diminish them, but sometimes it's difficult. So, for example, if I go for the all-in-4, it's impossible to avoid it. Okay. So this is why it is a question mark. But to try to not to overload the implants when they are never first, but especially when they are in the first months of the osteointegration. So in terms of advantage and disadvantage, when we go for immediate function, of course, treatment time reduction, cost reduction, surgical procedure simplifications, one surgery, we can immediately soft tissue conditioning, more comfort for the patient. It's also in terms of psychological and emotional benefit for the patient. You can deliver immediate static and function, which will immediately improve. It has high success rates. We don't have any transitional prosthesis, and it's improved accepted rates. So not only the accepted rates are improved, but actually nowadays our patients are demanding it. So in terms of disadvantage, unfortunately, it's not possible for all clinical situations. Sometimes you have big infections, or which you then have to compensate somehow, and you want everything to heal and not immediate load. Sometimes the bone is very soft, but also it's depend on clinical experience, on the learning curve. It requires always to have a good support on the implant stability, and of course also it's demanding because you have to have a good strict patient compliance, and this is a big requirement so that you can control all the healing phases from your patient. So guidelines is, yes, you can provide with immediate restoration, improving phonetics, statics, and mastication. Do not forget, I always tell you this, to have implant site in the preparation in order to achieve a good primary stability. We already talked about having a good stability, what you can do to have a good stability: bicortical, on the preparation, longer implants. Well, use the correct design of your implant and have good protocols. When you talk about bridges, partial cases, or even cases of total edentulous, you have to have protocols, you have to have very well distributed implants. So take advantage from the bone volume that you have, both in maxilla and both in the mandible. And when you provide your patient with a fixed bridge, please avoid in the provisional prosthesis to have cantilever. So no cantilever on the provisional prosthesis because of the occlusion. This is very important. So with this, I say thank you to you I hope I could share a little bit of my practice with you of some of my cases. Again, I leave here my social media where you can find me, where you can write me. Feel free. We can share. You can share cases with me. I can give you also my hints. And if you see me somewhere, please say hi. And thank you to you again. See you next time.